Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
So hello everyone, and thank you for participating in this webinar on the evolving treatment landscape for metastatic hormone-sensitive prostate cancer, or mHSPC, where we're going to talk about the latest clinical data and implications for practice. So I'm joined by my colleague and friend Neil Shore that will introduce himself, and I'm Fred Sad. I'm at the University of Montreal and I chair the Department of Surgery, and I'm Director of GU Oncology at the University of Montreal Hospital Center. So I'll let Neil say a few words about himself. He's got a lot to say. He's been around for a long time and one of the most active urologic oncologists in the world, I would say, in dealing with prostate cancer.
Well, thanks so much, Fred, and what a great pleasure to be with you. I think you and I have really shared a passion for our colleagues in urology, whether they're in academia or in the community, to really truly appreciate the expanding role of uro-oncology, and that doesn't preclude working with a multidisciplinary team. It just is recognizing the importance of systemic therapies that augment oftentimes our surgical interventions, and when our surgical interventions are not appropriate, we can work better together with systemic therapies. So I'm the medical director of Carolina Urologic Research Center in Myrtle Beach, South Carolina. It's great to be with you, Fred, and it's been a great journey, and there's so much great and great new therapies in progress for our colleagues who are listening to this program today.
So thanks, Neil. It's always a pleasure to work together, and 30 minutes is going to go by like a flash. There's so much we can say, but we'll try to concentrate on the topic on hand today in terms of dealing with metastatic hormone-sensitive prostate cancer. So let's start off with a quick polling question to get a sense of how people practice and their experience. So what percentage of your patients with metastatic hormone-sensitive prostate cancer do you feel can adequately be treated with ADT monotherapy?
Yeah, I think it's going to be really interesting to see the results here. I think we're going to have a global audience, and of course, do you have accessibility to some of the remarkable trials that we're going to address today? And our title is evolving. We can make the argument that it's evolved and continues to evolve. So I'll be fascinated to see the results of the poll.
Yeah, so this is a wider distribution than I would have expected, where actually about 10-11% would say the majority of patients can adequately be treated, and then it's split. I'm actually quite surprised with this, Neil. Any thoughts before we get into some of the data that might support not treating patients with ADT alone?
Yeah, it is so interesting that since 2017, and we're going to go over this, we've had a doublet therapy or couplet therapy, level 1 evidence now in the guidelines where where monotherapy ADT is no longer an adequate choice. I understand how sometimes patient fragility and other issues could come into play, but I think this is going to give we have our work challenge for us now to really hopefully convince everybody that doublet and sometimes triplet therapy is undoubtedly the way to go.
Yeah. So how would you have voted for that, Neil?
I would have voted less than 5%.
Yeah. Yeah, same here. I would say less than 5%, but we might be privileged where we have easy access, where we do this ourselves. And so, I can understand there might be some challenges in some places, but clearly I think what we want is at least to generate some reflection on the use of ADT alone. So we've both been in practice for about 30 years, and things were pretty depressing when we started our practice and when we were residents, where we only had ADT where we could offer patients. And my staff used to tell me, don't even give ADT until they're symptomatic from their metastatic disease. I mean, leave them alone. And then we started to have some therapies that became accessible. And really, about 20 years ago, it was only docetaxel that was available. And that was a little depressing because it wasn't, the easiest. And so the choices were really limited, but we can say that it was easy to treat patients, even though it was depressing. There wasn't much thought in treating these advanced metastatic patients. But just as an introduction of what happens when we do ADT alone in a contemporary cohort where we have therapy post ADT for metastatic CRPC. So this is coming from the Stampede data where they published on about 1,000 patients treated with ADT alone upfront, which was the control arm in Stampede, and they left therapies for when patients become mCRPC in that control arm. And obviously, the treatment arms received more than ADT, and we'll go over some of that data. But I think what's really fascinating or depressing, if you want, is that on average, and these are low and high volume patients, they're not all really high risk patients, they become mCRPC within about a year, which is consistent with subsequent trials since then. And what's even more depressing is that they only live 3.5 years. Even though we have docetaxel, we had ARPIs available, we really didn't do much better than what we were having with about a 3-year survival for mHSPC when we had nothing to offer them when they became mCRPC. So really, if you wait for mCRPC, it's a little discouraging that that might be effective, but much less effective than if you introduce it at the time of diagnosis of metastatic hormone-sensitive. And without going through all the details, there are 4 therapeutic options presently available in doublet form. So adding to ADT, whether it's docetaxel, apalutamide, abiraterone, or enzalutamide, consistently show that we can delay progression, but importantly, we improve overall survival very significantly in these patients, much more so than when we use the same therapies in the castration-resistant setting. So, there's a consistency here that any effective therapy we give over ADT, we're going to do a lot better than ADT alone. And then for a long time, we had to choose between chemotherapy or a hormonally based or an ARPI in combination with ADT. And that changed more recently with ARASENS and PEACE-1 that showed that we can do better than ADT and docetaxel. Adding abiraterone in PEACE-1 improved outcome, especially in the high-risk patient or high-volume patient, and adding darolutamide to docetaxel significantly improved survival over ADT and docetaxel, which was already one of the best standard of cares we could offer patients when they were diagnosed with metastatic hormone-sensitive prostate cancer. But Neil, you and I have been discussing this for a long time. What remains a little bit unclear is who's actually benefiting from docetaxel. I think it's clear that all patients benefit from an ARPI, but who's benefiting from the addition of docetaxel to the hormonally based doublet? So any thoughts, or I know it's not an easy one I'm throwing out to you, but.
Yeah. Well, it's incredible the enormity of you just showing 6 Kaplan-Meier curves. You just showed 6 Kaplan-Meier curves, 3 with oral therapies, Enza, APA, ABI, which clearly demonstrated benefit in low and high volume patients. The charted trial, which clearly benefited high volume patients, ADT and DOSI. And now the triplet data, the last 2 Kaplan-Meiers you showed, which undoubtedly shows the value proposition for patients getting triplet therapy. And remember, the docetaxel is just 6 cycles, so you're done with that in essentially 4 months. And these tend to be younger patients, and they tolerate it well. And they need to be, to your question, they need to be chemo eligible. And they are typically going to be high volume by definition liver, pulmonary lesions, high volume bone disease, probably 10 or more bone lesions. But so much of this is, shared decision making, which is super important, explaining to patients that monotherapy ADT, 6 Kaplan-Meier curves, which reflect 6 global trials that are now incorporated into the guidelines universally. And that's why, unless the patient is really frail, which I think it's less than 5% of patients in my practice, would only benefit from monotherapy ADT. I mean, this slide alone is unbelievable. And now we're going to talk about a 7th trial that you led and that further adds. So I guess one of the things, Fred, is we just can't say we give monotherapy ADT, the PSA goes down very, very low, or maybe even undetectable, and declare victory. Because all these trials show, and that early Stampede data that you showed, it's just no longer acceptable.
Yeah, totally agree. And so you nicely address who benefits from adding docetaxel at ADT, and I think that was a very nice description. It's really comes down to the fact that in metastatic hormone sensitive, you've got variable risk factors, and the highest risk are the de novo synchronous high volume that you very nicely described. These patients are the ones that are going to die the fastest, progress the earliest. And there's an urgency to do the maximum as early as possible. And the other extreme, these are relapse, metachronous patients we've operated on, got radiation therapy, recur a long time after, and with low volume metastatic disease. These patients, I don't think need very aggressive therapy unless they've got reasonable survival. And so I think who needs more aggressive therapy, such as the combination of docetaxel and hormonal, is going to depend on where they lie here. But I think we both agree that they all need at least ADT plus an ARPI. They need the doublet hormonal therapy to stay away from progression and stay away from the lethal form of prostate cancer, which is mCRPC, which is basically what kills patients. So you touched on this, that I presented recently, results that we both co-led in mHSPC to add another therapeutic option, which is darolutamide, that was shown to be effective in non-metastatic CRPC and improving overall survival, and you co-led that study. And in ARASENS that we were both involved in, where darolutamide added to docetaxel significantly. And so now the missing link was, well, in hormone-sensitive metastatic prostate cancer, can darolutamide alone in combination with ADT be a therapeutic option, recognizing that there are patients who don't need docetaxel. And so this is something that was felt to be needed to be confirmed. And so this was a 2-to-1 randomization. Patients with metastatic hormone-sensitive prostate cancer were randomized to darolutamide or placebo plus ADT with an rPFS endpoint, since we already had 2 phase 3 trials that showed that darolutamide improves overall survival. So we had that as a secondary endpoint, but multiple other secondary endpoints that were very important, like delaying mCRPC and trying to delay progression of pain and getting the best undetectable PSA rates. So what were the results? In a nutshell, the study clearly met its primary endpoint with a 46% reduction in the risk of radiological progression or death. And at 24 months, 70% of patients had not yet progressed or died in the darolutamide arm versus 50% in the placebo and ADT arm. So again, confirming that these patients have more than PSA progression, they have radiological progression in about 2 years if left on ADT alone. And then importantly, the lethal form of prostate cancer, which is metastatic CRPC, and patients just don't die of prostate cancer until they become castration resistant. There was a 60% reduction in the risk of becoming mCRPC and a 28% reduction in pain progression, which is quite unique. We haven't seen much in terms of symptomatic progression in other trials in this space. And importantly, we're getting to that undetectable PSA level of less than 0.2 at any time during treatment in more than 3 times as many patients. So when you give ADT alone, yes, you get undetectable PSA in some patients, but it's less than 20%, and that goes over 60% with adding darolutamide, and PSA progression was delayed by almost 70% in patients on darolutamide. So clearly there are multiple aspects that are strongly positive, and given all of these results, it was presented at ESMO and published in JCO simultaneously. So at the time of primary analysis, because the question comes up, well, what about overall survival? We only have about 2 years follow-up, so it's still early for overall survival, but already we're seeing a 19% reduction in the risk of death, even though the data is immature and the study was clearly not powered for overall survival. So I think we've got another positive study, very important. But I think one of the things that people want to hear about, Neil, is what is the price to pay in terms of toxicity by adding these kind of therapies? So maybe you can walk us through some of these aspects of how patients tolerate these therapies.
Yeah, so thanks for that great summary. And just a quick thing, we had a very high non-white population, which showed excellent results because we had a large Black population from Brazil. So I thought that was really great in our trial for the ARANOTE. And we saw, when you look at the forest plots, really excellent responses, not only in high volume, but remarkably in the low volume patients too. And while I'm saying all that, hopefully the audience is having an opportunity to scan the column for treatment emergent adverse events and look at the therapeutic treatment arm of daro plus ADT versus placebo plus ADT. And one has an opportunity to look at the exposure adjusted incident rate and the incidence. And essentially what you see here is a really well-tolerated combination therapy. And one of the reasons I got very interested in darolutamide early on was the fact that in preclinical models, it doesn't cross the blood-brain barrier. So in all various preclinical rat, mouse, dog models, and we've known that the AR pathway inhibitor drugs, earlier approved drugs such as enzalutamide and apalutamide, have always had a contraindication to using those drugs in patients who've ever had any sort of seizure history. That's never been a contraindication for the use of darolutamide in all the trials that we've done because of this preclinical demonstration of not crossing the blood-brain barrier and stimulating the GABA receptors. And so when you look over here with cardiovascular, when you look at things that could affect neuro-oncologic parameters like falls, I think it's really nice and very reassuring to see the tolerability of this combination. And that last slide too that you showed, that marked difference in the PSA undetectable range, it was roughly 60+% to 18%. And you've done great work in demonstrating that profundity of the PSA decline is really a prognostic of response for these patients, which is why that's such an important parameter throughout other studies too, and recognizing why monotherapy ADT alone is not adequate. And then just kind of looking further on, looking at any adverse events, all grade, relatively comparable. These are patients with metastatic disease, and these is any AE reported. But when we start to look at the AEs in greater than grade 3 or higher, interesting when one looks at, latitude, when one looks at Titan, there's a little bit of a difference in the signaling, not so much so in arches. But I do think when you look down at the bottom, again, a fatigue of all grades, there seems to be an absolute differential when one looks at the ARANOTE study. I think it's important that our colleagues who are listening, whether they've had experience with one or all of these drugs, I certainly encourage to get experience with all, whether you're using it in mCRPC or an NMCRPC or mHSPC, you'll start to get a recognition about overall tolerability. And I think there was nothing surprising here in the ARANOTE study. Now, drug-drug interactions are really important for everyone. No one can ever remember all these different DDIs or drug-drug interactions, but most of our patients are on multiple therapies, antihypertensives, anticoagulants, antithrombotics, the PD5 inhibitors, et cetera, et cetera. You can figure out DDI challenges with either dose reductions or con med substitutions if you're using some of the other ARPIs. But I do think, and we published on this previously, that you do generally see less DDIs for the use of darolutamide given its metabolism. So when should we still offer a triplet therapy? You alluded to that earlier, Fred. I think that I'd like for you to address that now. We have this remarkable embarrassment of riches. And even though it was depressing 30 years ago and somewhat nihilistic, we were like, oh gosh, once you progressed after your ADT, we could really offer nothing. So it was depressing and there was nihilism. But that is clearly no longer the case. 20 years later, in addition to now having 7 mHSPC trials which show superiority over monotherapy ADT, we also have another 5 or 6 novel mechanisms of action that are life-prolonging in CRPC. And of course, as you said really nicely, in the mHSPC, we want to delay that conversion to resistant disease for as long as possible. So Fred, when somebody comes in to see you, when do you tend to encourage them more for triplet therapy as opposed to doublet?
Yeah, basically, unless there's really an inability to tolerate docetaxel, I discuss it with almost every patient. And then obviously we have to put the things on our cards on the table, and patients are going to ask, well, do I really need it? And there are some patients that I will more strongly encourage, patients like you mentioned, high volume disease, especially with the presence of visceral metastatic disease. Patients who come in with symptomatic hormone-sensitive disease, we don't recognize how important that is as a prognostic marker. And that was reported very nicely at ASCO GU, that in itself is a prognostic marker. So patients need to be informed that there are options and that we are limited in our capability of telling them 100% who's going to benefit. But basically, I look at a patient and I say, this patient's going to need chemotherapy relatively soon. So I'd rather give it upfront rather than wait for them to become resistant to an ARPI, where chemotherapy, unfortunately, is much less effective. So a younger patient, even with low volume disease, there's going to be a big discussion about the use of chemotherapy. And almost any patient who can tolerate chemotherapy with high volume, especially visceral metastatic, the discussion has to be made. And ultimately, the patient needs to be the ones who are the most involved in making that decision. And so, like you mentioned, things have changed dramatically in our career of what we can offer. And anybody who thinks they can do this all alone, I think doesn't realize. And so the team effort, the multidisciplinary aspect is extremely important. And all of these people need to be involved, either immediately or at some point, keeping in mind that the patient has to be central to all of this, all these efforts, because these patients are going to die. The vast majority are going to die of this disease. So we have to do it right. And the best treatment, the best results are what we give them first.
Yeah, I couldn't agree with you more on this. And there's just, we're underutilizing level 1 evidence of doublet and triplet therapy. We're underutilizing genetic testing. As we saw on that last slide, the potential for PARP inhibitors for patients who could benefit, PARP inhibitors in combination with ARPI drugs such as abiraterone and enzalutamide. And we're even underutilizing the use of somatic testing too for the occasional patients who have TMB high or MSI high for checkpoint inhibitors. And there's more and more information that's going to come forward. But it really starts now with mHSPC, and some would even argue, and it wasn't the topic of our presentation today, that even with high-risk BCR, monotherapy ADT is not necessarily the optimal choice. So recognizing that we've come a really long way, And then, of course, one of the things that you've been world leading on is the importance of bone health and anti-resorptives for maintaining bone health integrity. So this wheel, I think, is great because it tells our uro-oncology colleagues we need to work collaboratively given the complexity, but it's a great problem to have.
Yeah, couldn't agree anymore. So we're coming close to the end of this 30 minutes. As expected, time flies, and this has been a really great discussion. So we've got a couple of questions we'll try to address in the time we have left. So would offering combined chemotherapy and an NHT from the onset be beneficial in certain conditions? And I think we addressed that. But I think what the question is, should we take a stepwise manner? Should we start with one and then see how they respond and add the other? So what are your thoughts on that? I mean, try ADT alone and see what happens, or ADT and
Yeah, I never do ADT alone except in the patients who are just, for whatever reason, their personalities are really fearful about multiple drug combinations despite my best efforts showing the safety tolerability data, or they're uber frail. I was giving ADT and docetaxel and then sequencing to an ARPI before piece one and Arasens read out. I think you and I have been pioneering on the importance of uro-oncologists to be comfortable in giving taxane-based therapies. I know we both give docetaxel and cabazitaxel. I've never felt that whoever can give it, the med-onc, the uro-onc, as long as the patients are given an opportunity to get therapy. The trials, the piece one and the Arasens, were all based upon a concomitant use of Abi or Daro. Can we give it right after the 6 cycles are given? I don't think that that's necessarily terrible to do if it makes patients feel better. But, I will tell you, Abi overall is a very well tolerated drug. It has different AE profile. And darolutamide is really so well tolerated. I'm very comfortable in giving it concomitantly with docetaxel when I have to.
Yeah, absolutely. I totally agree. And sometimes PSA is our worst enemy. Like you said, we saw it go down, and then both physician and patient think, well, maybe we don't need to do more than that. And that's really a mistake, because it'll go down in almost all patients. How deep it's going to go down and how long it's going to stay in remission is really the question. And I think we have to be cognizant of that and tell patients that, yes, PSA is going to go down with ADT alone, but won't stay down and definitely won't go down as deep. I
think we should go to do you want to go to the poll?
Yeah, we'll go back to the poll question because I saw it. So let's go back to the first question we asked after having discussed this for the last 30 minutes, and have people re-vote on the use of ADT monotherapy when you feel it might be adequate and what percentage of patients can adequately be treated. So let's re-vote. Same question, 5%, 15%, 30, or greater than 50% of patients could be treated with ADT alone. So we do have a reduction in the number of people that feel it would be appropriate, and an increase in the ones that said it was less than 5%. So I think we're progressing. So I really enjoyed this discussion, Neil. Obviously, we could have taken 2 hours and we still wouldn't have covered all we can cover. So we purposely had to keep it high level, but hopefully people will find will find this to be informative. There's still work to do and figure out why they're getting ADT alone. There are some things that we can change and some things that we can't. But I'd like to say thank you to Neil Shore for having been part of this with me, and thank you very much, and have a great day, everyone.